right, hello. We are doing our presentation on heart failure. My name is Bella, and presenting is Claudia, Christina, JC, and myself. All right, so heart failure. What is heart failure? So basically, it's just a general term for the inadequacy of the heart to pump blood throughout the body, which causes insufficient perfusion of body tissues with vital nutrients and oxygen. So depending on what kind of heart failure you have, either left or right, you'll have kind of different symptoms. Um, but normally, towards the end, the heart will fail from left side to right side, and then you'll start to experience these symptoms of shortness of breath, swelling of the legs, hands, feet, sudden weight gain, chest pain, especially on exertion. All right, so patient introduction. Our patient is a 71-year-old male with a history of BPH, PVD, MDS, and 6 weeks ago, he was admitted because he had a syncopal episode. He was diagnosed with paroxysmal atrial fibrillation and acute anemia with a hemoglobin of 6.9. He received a blood transfusion of packed RBCs. So right now he presents to the ED with increasing weakness, fatigue, sinus congestion, fever, chills over the past week. He was around grandchildren with colds 2 weeks ago. He woke up at 6 a.m. today feeling kind of short of breath, coughing, clear sputum, and he had difficulty walking back to bed after getting up to the bathroom. So increased shortness of breath upon exertion. And his wife, who's a retired nurse, noted that he was much paler today and took his vital signs where his blood pressure was 96 over 62. He had a 140 heart rate and it was irregular, respirations of 24. And he admits to losing 15 pounds over the last 2 to 3 months. All right, so past medical history, again, benign prostatic hyperplasia, which is a non-cancerous enlargement of the prostate gland, very common in older men, peripheral vascular disease, and MDS. So that's basically a disorder of the bone marrow where it doesn't really produce enough healthy blood cells, which leads to problems like anemia, infection, or bleeding. And then recently, the diagnosis of paroxysmal atrial fibrillation, which is just a type of arrhythmia that comes and goes. And it's characterized by episodes where the heart beats very rapidly and irregularly. His home medications include clopidogrel, tamsulosin, and atenolol. So those medications, the clopidogrel is used primarily for preventing blood clots, especially in conditions like PVD. So it's an anticoagulant. Sometimes it's prescribed aspirin. Sometimes this is prescribed. Tamsulosin is used to relieve symptoms of BPH by relaxing the muscles in the prostate and the bladder neck, improving urinary flow. And then atenolol is just a beta blocker, which helps with the atrial fibrillation. So psychosocial priorities. So he's retired, lives at home with his wife in a rural area. He has 2 children that live out of state. So he's been pretty active. He's healthy male. He enjoys gardening, hunting, splits wood to heat his home in the winter. And he has been dealing with changes in his health as he's not really been able to do the activities he wants to do due to his shortness of breath. Upon activities. And in the past, he's been employed as a minister, so he has a strong Christian faith, and he denies any smoking, alcohol use, and illicit drug use history.
So upon assessment, he appears ill and weak. He's barely able to stand. Currently, he's in no acute distress, but he's also having some decreased appetite. He's alert and oriented ×4. He has muscle strength 5 of 5 in both upper extremities and lower. Symmetry of all facial features, pearl as normal and white sclera. His conjunctiva, pale bilaterally. Lips, tongue, and oral mucosa also pale and dry. Respiratory, the sounds are bilaterally fine crackles and basses. Slightly labored respiratory effort on room air. He has a persistent cough with clear sputum. His cardiac, pale, warm, and dry, 1+ edema. Heart sounds are irregular and tachycardic. Pulses are faint, equal with palpitation at radial, pedal, post-tibial landmarks. Cap refill is brisk. No distension of his JVD. He's sitting at a 30 to 45-degree angle. His abdomen is round, soft, non-tender. Vowel sounds are present in all four quadrants. He's voiding frequently with hesitancy. Urine is clear, dark, and amber. His skin is dry and intact, pale nail beds. Skin integrity is intact. His skin turgor, mild tinting. His telemetry reads irregular pulse, has no P wave. His PR interval is irregular to calculate. QRS is 0.06. QT is also irregular, and we interpreted this strip as atrial fibrillation.
The radiology results came back with bilateral diffuse pulmonary. Infiltrates are consistent with pulmonary edema. The significance of this is that pulmonary edema occurs when the heart is unable to pump blood effectively, leading to fluid accumulation in the lungs. He also had various labs drawn, and there's a few of them that are outside of the normal ranges. This includes the white blood cell count with 6.7. It is improving, so hopefully that means that there's a decreased infection. His hemoglobin is a 6.2, which is worsening, which means that there is a decrease in deoxygenated blood. Platelets are at 81,000 with an increased risk of bleeding, which is also worsening. His sodium levels are at 135, which is within the normal range. However, they are worsening when trending, and low sodium levels can affect central nervous system in the brain. His albumin levels are 3.1. They're also worsening. This could be due to increased fluid overload. His alk phos is 272, also worsening, as well as the ALT and the AST, other liver enzymes, they are all worsening. His MAG is 2.2, also worsening, which could indicate muscle weakness, and BNP, which is at 475, also worsening, which could indicate fluid overload.
Priority problems, impaired perfusion and oxygenation caused by potential infection or his anemia. These can be evidenced by exertional dyspnea. He could be not tolerating activities, inducing some shortness of breath when lying flat or at rest. Also, there could be some fluid retention. We can manage that with getting accurate daily weights, and this should be taken to document fluid retention. Same time of day, same scale, and it's the most reliable indicator of fluid gain or fluid loss. So Bill has severe fatigue, pallor, and weakness. He's tachycardic and his blood pressure is low, showing signs of hypoxia. He has SOB and a productive cough with clear sputum. This could be indicative of infection or anemia, as well as fever and chills. Interventions we're going to administer some oxygen for the hypoxia. We want to do some early detection before he deteriorates. We want to obtain some labs, CBCs, blood cultures to identify the severity of his anemia, also infection and metabolic imbalances, and treat whatever labs are off. We want to assess vital signs, monitor for signs of sepsis, because this can be life-threatening to him, especially because he's immunocompromised. We want to prepare for potential transfusion if his hemoglobin becomes critically low. This will restore his oxygen carrying capacity in severe anemia, improving his perfusion and reducing his fatigue and weakness. We're also going to initiate IV fluids if dehydrated or hypotension persists. We want to make sure he's hemodynamically stable and improves his circulation and support his organ perfusion. If his labs come back and the white blood cell counts are low, we want to administer some antibiotics, or high, sorry. If his white blood cell count is high, we're going to give him some antibiotics and treat this infection.
So his evaluation, this is 2 hours later, after we've implemented all orders. Bill has been admitted and transferred to the cardiac telemetry unit about an hour ago. He is now able to walk from stretcher to the bed and was steady on his feet. His most recent vital signs are 37.6 Celsius. Pulse has decreased to 108, but still irregular. Respirations decreased to 20. BP at 108 over 54. And O2 saturation 94% on now 2 liters via nasal cannula. His breath sounds remain diminished bilaterally with fine crackles in the bases. He doesn't feel any shortness of breath and is breathing comfortably. Rhythm still shows AFib. Blood is infusing at 150 ml an hour, and diltiazem infusing at 5 milligrams an hour in a separate IV. Bill complains of pain that just started where his IV is infusing, and observed looked puffy and cool to touch. Based on that current assessment, he still has AFib, so there's no change in that. Heart rate has decreased to 108, which is improving. Respiration rate to 20, which is improving. BP, there's no change. O2 saturation can be improving or declining. He is now up to 94%, but is on 2 liters via nasal cannula. He's able to walk from bed to transfer cart, which is an improvement. Again, with the diminished bilateral sounds with fine crackles in the bases, that remains the same. And the new complaint of pain where his IV is, that should be a decline. There were no previous reports of pain, and this could be a sign of infiltration. Overall, it seems like Bill has improved, but there's some additional interventions we would like to add. We want to continue monitoring cardiac rhythm. Outcome would be patient will have decreased episodes of AFib before discharge. We want to discontinue his current IV and begin a new line at a different site. Patient will have a new patent and working IV line. Recommend to provider for antiarrhythmic medications. Patient will have decreased episodes of AFib after discharge. And last, we want to recommend a follow-up with the provider for possible labs, weight check, and EKG. Outcome for that will be patient will have at least a hemoglobin of 10, no weight loss or gain of 1 kilogram a day, and a normal sinus rhythm 2 weeks after discharge.
Based on that assessment, we have a bit of an update after the fact. And so Bill has converted back to sinus rhythm. His hemoglobin is 8.9. And so he will be discharged to home tomorrow on an enoxaparin subcutaneous, which is to counteract blood clots. So we are going to consider the different educational priorities for this patient and his family to successfully manage the current problem and to maintain an optimal state of health. And so the priority topics that we would like to talk about include infection control, such as hand hygiene, vaccinations, avoiding crowds and those who are ill. He is very susceptible to infection, and this could quickly lead to sepsis. He should follow up with a medical provider and also redo some labs. They should be monitored and also need trending, as there were some concerning results, and then also along with the losing weight. Enoxaparin subQ medication teach is super important. It is a high alert medication used to prevent blood clots and can help with complications from angina and heart attacks. However, he needs to know how to administer that correctly, as well as to continue to monitor labs such as the ALT and AST, as it is known to cause an increase in these. Bill should be wearing a medical bracelet and also let medical providers know about this medication, as he is at an increased risk for bleeding. In terms of signs and symptoms of stroke and heart failure, Bill should know what these signs and symptoms are, as well as his family. He is at an increased risk due to AFib recurrence and would then need immediate medical attention. This would be instrumental in getting the patient to definitive care in a more timely manner. And here are references. Thank you very much.